Okay, Assalamualaikum and good morning. In this session, I will be sharing some tips on how to approach the posterior block approach for the abdominal wall blocks. Maybe I will focus on the quadratus lumborum and also the erector spinae planes. Okay, when you want to consider using a posterior approach compared to the anterior approach, I would consider posterior approach if you were to provide anesthesia and require more extensive coverage, and also if you want to have a coverage of the visceral part, then you consider to block using the posterior approach. So we have two posterior approaches that is at the moment is in the clinical practice, and the quadratus lumborum and erector spinae are two of the more commonly discussed. And we have recent evidence showing that both the techniques are actually beneficial, although it is quite of low quality evidence at the moment, but there are some although smaller RCTs showing that there is a definite benefit. Okay, so how I would perform QL block. One of the most difficult things to identify is where is the actual QL muscle itself. So I will share some tips on how to identify the structures. Okay, first, this is the iliac crest, and this is the subcostal margin. Okay, rough. So I will just focus on an area at the midpoint between these two lines, and I would draw one line midpoint going towards the spine. So I can actually for QL block, patient is in a lateral position and we'll be using low frequency curve probe. Okay, once you've actually identified, okay, this is the on the right side of the screen is the posterior end, and the left side of the screen will be the anterior end. Okay, so I usually put my probe in between these two landmarks along this line, so you can actually move along this line, okay, for you to identify the quadratus lumborum muscle. Okay, there are two ways of how to identify. You can actually start from anterior. Okay, start from anterior. Identify the three layers of muscles, the anterior abdominal wall muscles. The thickest would be the internal oblique. The one more superficial to be would be the external oblique, and the one innermost will be the transversus abdominis. So you can actually come from anterior and slide the transducer laterally and going posteriorly until you see common aponeuroses of the internal and transversus abdominis. Once you see this common aponeuroses, the muscle just directly below is the quadratus lumborum muscle. It is the hypoechoic rounded structure being shown by the pointer. Okay, so this is one way of how to identify from anterior. Okay, the other technique is by just increase the depth slightly. Okay, I'm sure that many are aware of the Shamrock sign. This is what is being commonly used to identify the quadratus lumborum. Okay. Again, looking at the points in between the costal margin and electrice, just put your probe at the center. Increase a bit of the. Okay. So this is what we identify as the thumbs up sign. Okay, the transverse process is the thumb, while the vertebral body is the knuckles. Okay, so this is one another sign that you can actually use to identify quadratus lumborum. And the quadratus lumborum is always at the tip of the thumb. So that is the quadratus lumborum muscle. Okay. Anterior to the thumb will be psoas, and posterior to the thumb will be the erector spinae muscle. Okay, so this is how you would identify quadratus lumborum, and you can actually perform the various approaches of the QL blocks that has been described by Dr. Nabila in her lecture. Okay. There are evidence to show that anterior QL has more benefit than the other approaches, although it is of low quality evidence and the numbers are actually small. So I will show you how I would perform a anterior QL block. So once you have identified the structures, you've identified the thumb, identified the QL muscles, and if you look at the line that I've drawn here, this is the plane where you would want your needle to be. So for optimum visualization of the needle, I would recommend needle entry point to be slightly paramedian rather than closer to the transducer. Okay, I would rather because if you insert your needle from here, you are actually going to be tangential to the beam, and you can actually see your needle better. Okay, so this is one of the key points that you would want to consider when you're performing an anterior QL approach. Okay, so this is again the thumb and the knuckles, and the thumb always points to the quadratus lumborum muscle. So that is one of the take-home message. Okay, next I will be showing the erector spinae plane block for abdominal surgery. Okay, for that we will use the linear high frequency transducer, and we adjust the depth appropriately. Okay, erector spinae plane block was actually described for thoracic or chest wall procedures. So it is essentially the same in principle, and you identify the landmarks similarly, just that there are some key points that you need to consider when you are actually looking to block the abdominal wall. Okay, so first, orientation of the probe. Left side of the screen will be caudal, right side of the screen will be cranial. Okay, so for landmark identification, the spine of the scapula corresponds to T3 level, thoracic 3 level. Okay, so spine of the scapula roughly T3 level. Inferior angle of the scapula corresponds to the T7. and you have iliac crest, and the midpoint between T7 to the iliac crest roughly is the T12. So if you were to consider blocks for the abdominal segment, so the area of block would be roughly from L1 to T5. So roughly around there. So this is the part where you want to consider siting your injection and depositing your local anesthetics. And where it is specifically depends on what are the incisions that the surgeon is making. So this is the area that you want to consider siting your local anesthetics. Okay, so looking back, okay, the probe is placed in the long axis. At the midline, you can actually identify the spinous process, the spinous processes. Okay, you can see superficial hypoechoic structures. Okay, so those are the spinous processes. And as you go laterally, the hypoechoic white lines that you saw superficially now goes deep. These are the lamina. Let me just increase the depth. Increase. Hold on. So that's the spinous process, and you go more laterally and you see the lamina. So the high hypoechoic structures you can see now going down into the screen deeper. And as you slide more laterally, you can see a flat hypoechoic structure. So that's the transverse process. Okay, as you go slightly more lateral, the flat surface becomes more wavy, and you can see if you remember our physiological days, you can actually can appreciate this as the dichrotic notch of an arterial waveform. So this is part of the plane that is actually at the costo-transverse junction. And as you proceed more laterally, you can appreciate that the flat hypoechoic structure now has become slightly more rounded, and you can see the pleura lines sliding clearly. So this means that you are actually at the rib. Okay, so again, going back to midline, that's the spinous process. Move laterally, that's the lamina. So the high white becomes low white now. You move more laterally, you see the flat transverse process, and you can see some faint lines of the pleura. You move more laterally, you see structures becoming more rounded. The hypoechoic structure becomes more rounded, and the pleura is more clear. So that this is you are at the rib. Okay, now try and appreciate the layers of muscles just above the transverse process. Now I'm sliding my probe back medially onto the transverse process. Okay, so if you see the muscles on top of the transverse process, you are going to see 3 layers of muscles. The trapezius, the more thin and more hypoechogenic rhomboid, and immediately above the transverse process is the erector spinae muscle. Okay, you can see the 3 layers of muscles. As you go caudally, you can see the layer, the rhomboid becomes tapered. This is approximately at the T5 level. Okay, so if you want to perform the ESP and provide blocks of the chest wall, this is your lowermost margin. So you can actually block ESP proximal to this line. Okay, so anywhere below, you are actually blocking T6. So anywhere below this margin, you are actually blocking the anterior abdominal wall. So depending on where is the incision, so this is the most cranial line, and you can actually perform the block anywhere here depending on the incision. So for example, let's say for upper abdominal surgery, then I would deposit my local anaesthetic roughly at T6 to T7. So roughly, okay, that's a T5. So roughly here, okay. So you can actually place your needle tip at the tip of the transverse process and deposit your local anaesthetics. And we usually deposit around 20 to 25 mils of local anaesthetics. And it is mentioned that for thoracic wall blocks, you need to deposit at least about between 2.5 to 3.5 mils per vertebra, whereas if you want to block the lumbar segments, then you need to deposit about 5 mils per lumbar vertebra. So depending on what type of surgery, what are the incisions, then those are the volumes that you need to consider. Okay, so again, key points will be the T5, which is the end of the rhomboids. Okay, so this is the transverse process level because of the flat hyperechoic bony structure. And you can see from 3 layers of muscles, now it has become 2. So this is where you would start, and depending on the incision and what type of surgery, this is where you would consider depositing your local analgesics. Okay, so you can either place your tip of the needle at the transverse process or anywhere below the plane of ESP, in between the 2 transverse processes. So you can actually deposit your local anesthetic there. Okay, since we have time, there's another approach of block that you can actually perform, especially for the upper abdominal surgery, which is the Serratus plain block. People, I think many are aware that Serratus plain block is associated with chest wall surgery or even breast surgery, but it is actually using the knowledge of anatomy, you actually can provide analgesia for the upper abdomen. It is the key point here is where you would site your injection. For chest wall, for breast surgery, the key landmark will be the nipple line. So, and also if you count the ribs from anterior to axilla, you have to deposit your local anesthetics below the 5th rib. So okay, the right side of the screen will be posterior, left will be medial. So at mid-axillary line, okay, make sure it is below the nipple line. So at mid-axillary line, there is only the serratus anterior. Okay, so for upper abdominal surgeries, you can actually block the nerves at this plane. You actually can deposit your local anesthetics at the superior part of the muscle or even below. Okay, studies have shown that the superior or the superficial deposition of local extends quite extensively, and you can provide coverage of multiple dermatomes. So you just make sure that your probe is below the nipple line and put it at the mid-axillary line, okay, and try to look at the point where there is only the serratus anterior muscles. It is easy at the mid-axillary line because that's the only muscle that you can see above the rib. So you can come actually from posterior, okay, and deposit the local analgesic superficial to the serratus anterior. So with that, I've demonstrated 3 blocks of the posterior wall, of the posterior approaches of the abdominal wall blocks. If you have any questions, then we can actually write in the chat box and we will try and address them later. Thank you very much.